I want to give 4 recommendations to you. The first one is, please always remember that antipsychotic drugs are not schizophrenia treatments. As the name says, they are drugs against psychosis, irrespectively of where the psychosis occurs. For example, they're also effective for psychotic depression and also for psychotic mania. This is important because there are also situations where in schizophrenia antipsychotics are not beneficial. One example is catatonia, where the primary recommended treatment is benzodiazepines, and antipsychotics, if any, only are third line. And why is that? Because antipsychotics go on the motor system, and this is something that we do not want in the treatment of catatonia. Another example is cognitive deficits, which are very frequent in schizophrenia, and unfortunately, antipsychotics are not cognitive enhancers. My second recommendation is start low, go slow, but ultimately go. Whenever it is possible to do that, please proceed like that, because we want to avoid overshooting. We want to avoid excessive doses and then exposing patients to side effects which are not necessary. Ultimately, my third recommendation about dosing now is that please do not think linearly. This is something that we usually or often do in practice. If a patient has not responded, we think the patient needs more. But please remember that this type of behavior has its limits. Dose-efficacy relationships of antipsychotics are not linear, they're actually hyperbolic, meaning that there is a linear part, we increase the dose and efficacy increases, but then the relationship reaches a plateau, meaning that if we then increase the dose, we only get more side effects but not better efficacy. When does this happen? This happens when the mechanism of action of antipsychotics is fully exploited, and for almost all antipsychotics available, this is dopamine blockade. Why do we get side effects, more side effects at higher doses? This is because receptors which have a relatively low affinity to antipsychotic drugs with high doses have the affinity, and then these receptors lead to the side effects of antipsychotics. And my last recommendation is, please try to adopt shared decision-making whenever you can. What is shared decision-making? Shared decision-making means that we should inform patients about the general choices and then ask them what they would prefer. Why is this important? Because patients have different values. Some patients will say, I never want to have weight gain. Others will say, I've had extrapyramidal side effects, I don't want that again. And another patient might say, sexual side effects for me are a no-go. But ultimately, I also know patients who say, please give me the most efficacious drug as long as I will not have another episode of schizophrenia. This means that shared decision-making is not only a patient right. It's very clear that the patient actually has the right to choose a treatment and say yes or no to a treatment. But I think that this shared decision-making will also improve adherence of patients. How is shared decision-making applied? Of course, you can do this in a very operationalized manner, but for me, this is mainly an attitude. How do I approach my patient? Do I approach patients in a paternalistic way? I'm the doctor who knows everything, I take the decisions, but I also take the full responsibility, or do I rather involve the patients in the shared decision-making?